Hello, my name is George Nicholson. I'm one of the cardiology fellows, and I would like to provide a basic overview of EKG information and parameters. I would like to draw your attention to the image in the upper right-hand corner on the screen, and we'll discuss the different phases of the cardiac action potential. Phase 4 is known as the resting membrane potential, describes the membrane potential when the cell is not being stimulated. So in a standard myocyte, this will usually be a horizontal line. That's how you'll see it be drawn on a representation. The resting membrane potential is caused by the difference in ionic concentrations and conductances across the cell membrane. And the normal resting membrane potential in ventricular myocardium is about minus 85 to minus 95 millivolts. And this is predominantly determined by the selective permeability of the cell membrane to various ions. And predominantly, the resting membrane potential is dominated by the potassium equilibrium potential. And phase 4 is associated with diastole, so it's often referred to as diastolic depolarization. And these cardiac cells are self-activating. Although they do receive some input from the autonomic nervous system, they need no stimulus to fire. And it's the duration of this slow diastolic depolarization which controls the cardiac chronotropism. If you look at phase 0, this represents that the cell being electrically stimulated. And it's usually by an electric current from an adjacent cell. It begins as a sequence of actions that involve the influx and efflux of cations and anions that together produce the action potential of the cell. Phase 0 is the rapid depolarization phase. And action potentials are all or none signals. Either they occur fully or they don't occur at all. And the slope of phase 0 represents the maximum rate of potential change. And in heart muscle cells, this slope is directly proportional to the net ionic current. This phase is due to the opening of the fast sodium channels. It causes a rapid increase in the membrane conductance to sodium, which leads to a rapid influx of sodium ions into the cell. If you look at phase 1 on the myocyte, this occurs with the inactivation of the fast sodium channels. So the transient net outward current, causing a small downward deflection of the action potential, is due to the movement of potassium and chloride ions. And oftentimes, it's thought that chloride ions moving across the cell membrane during phase 1 is due to a result in the change in the membrane potential from potassium efflux. In phase 2, this is known as the plateau phase of the action potential, and it's sustained by a balance between inward movement of calcium and outward movement of potassium. Looking at phase 3, this is known as the rapid repolarization phase of the action potential. The calcium channels close while the potassium channels are still open. So this ensures a net outward current corresponding to a negative change in the membrane potential. looking at the anatomy of the heart's electrical conduction system and the corresponding configuration of the action potential curve, you can see that the action potential is quite different depending on the location within the heart. So up at the Sinoatrial Node, the action potential has one particular characteristic, and again this is due to differences in resting membrane potentials and the myocyte cell membrane's permeability to various different cations and anions. And also, if you look at the cartoon diagram there on the left, you'll see that the AV node kind of sits in what's known as the triangle of Koch, whereas it's bordered by the tendon of Todaro, the coronary sinus, and the tricuspid valve. And then once through the AV node, the electrical conduction follows very specific pathways or roadways through the bundle of His, then down through the bundle branches and into the Purkinje fibers to the ventricular muscle and myocytes themselves. Whereas in the atrium, the depolarization from the sinoatrial node to the AV node is predominantly from myocyte to myocyte. Corresponding in action potential to the EKG characteristics, you can see that during diastole, that represents phase 4, or the resting membrane potential, whereas phase 0 corresponds with the initiation of the QRS complex. And then phase 3, where you get a return of the resting membrane potential from positive back down towards negative, corresponds with ventricular repolarization. In looking at the specific labelings of a cardiac cycle on the EKG, it's important to know all the different labels. So the P wave corresponds to atrial contraction. The QRS complex corresponds to ventricular depolarization, and the T wave corresponds to ventricular repolarization. And then the different intervals are as named based on the specific measurement that's in question. So looking at the sinoatrial node, you can see, based on the cartoons here, of the right atrium, its location is predominantly in the upper lateral portion of that right atrium, near the entrance of the superior vena cava into the right atrium, and posterior to the right atrial appendage. And it has a horseshoe type of shape as well. Specifically looking at the conduction system, again, the impulse is generated from the sinoatrial node in an individual that has normal sinus rhythm and normal electrical conduction, and it predominantly propagates through the atrial tissue from myocyte to myocyte. However, there's only one way in a normal heart for the electrical impulse to go from the atrium down to the ventricle, and that is through the AV node, which on the diagram there is in yellow. Once through the AV node, the signal then propagates down a common AV bundle, otherwise known as the His bundle, and then branches off into a right bundle branch and a left bundle branch, so named for the respective ventricles that they then travel to. Once from the bundle branch, then travels down to the Purkinje fibers, and then into the individual ventricular myocytes themselves. And again, this is just a close-up of the AV node and a close-up of the bundle branch leading to Purkinje fibers. If you hear someone refer to the His-Purkinje system, this is what it entails. The bundle of His, or known as the common AV bundle, and again going into a right bundle branch and a left bundle branch. The left bundle then separates into a left posterior fascicle and a left anterior fascicle, whereas in the right there's only one predominant branch before both branches separate down into the Purkinje fibers. When we're determining the axis of the QRS complex, we use the limb leads as our determining measurements. This cartoon is important to put to memory because if your QRS complex is predominantly upright in lead 1 and predominantly upright in lead AVF, then you know that your depolarization axis has to be from the Sinoatrial Node down through the the AV node, then down through the Purkinje system. And the reason why the axis is important because your heart sits predominantly in this region right here. Your sinoatrial node is up in this area, so the electrical impulse generates here and propagates in this direction down through the ventricles. So the vectors on an EKG correspond with the directionality of the electrical current. So if the vector is predominantly upright, meaning that the current is traveling towards the positive deflection of that lead, so in lead 1 the positive deflection is here towards the left shoulder, and in lead AVF the positive deflection is here down towards the belly button. So again, if you have a QRS complex that is upright in 1 and upright in F, then the deflection or the vector relationship has to be positive in this direction, and that is known as a normal axis. Again, putting this cartoon to memory is quite helpful when you're reviewing an EKG. This is just another representation of the same cartoon, just in a little different configuration. So again, we still have lead 1 being positive over here at 0 degrees. Lead AVF is not labeled here, but it's at positive 90. Lead 2 and lead 3. So we say someone has normal range of axis if it's essentially from minus 15 to minus 30, up to an adult up to 110 to 120 degrees. Whereas someone has right axis deviation if their axis is determined to be in the plus 120 to positive 180, versus someone who has left axis deviation if their QRS complex axis is determined to be more negative than minus 30. It's important to note that the QRS axis, though, changes with age. And it can be pretty difficult to memorize these normals, but this information should always be readily handy. So in an infant, it's normal to have more of a right axis dominant, since in utero the right ventricle plays a more active role than the left ventricle. So therefore the right ventricular muscle will occupy more of the overall heart mass. So the vector of depolarization will be skewed slightly towards the right ventricle versus the left ventricle. Whereas in an adult with a normal heart, the left ventricle myocardium is thicker and occupies more of the percentage of myocardial mass in the right ventricle. So therefore, the depolarization vector is therefore more skewed towards the left. Also, it's important to note that the PR interval changes with age. And again, trying to memorize these numbers can be pretty difficult and frustrating. But this information is always readily available. And so I recommend just making sure you know where to get the information so that if there's ever a question on an EKG, you know where to refer to provide yourself an answer. But just note that in general, with age, the PR interval lengthens. And it should always be less than 200 milliseconds. In addition, the QRS voltages change with age as well. So in a newborn, the R wave will be less dominant in the left lateral leads than in an adult. And again, this corresponds to the change in the relative ratio of left ventricular to right ventricular mass. Whereas the S wave in a newborn in the left lateral precordial leads will be more dominant. And again, if there's any sort of question about if there is either left ventricular hypertrophy or right ventricular hypertrophy, just refer to the age-matched normals. So this is an EKG demonstrating normal sinus rhythm. And there's a few things that have to be met in order to determine if someone has normal sinus rhythm based on an EKG. You need an appropriate P wave access, meaning the P wave has to be upright in leads 1, 2, and AVF. In addition, your P wave has to be followed by a QRS complex, and a QRS complex has to follow each P wave. If you meet these criteria, then you can safely say that someone is in normal sinus rhythm. And again, the reason why the P waves are upright in leads 1, 2, and AVF is that if you go back to our cartoon demonstrating the lead axis or lead axes, if the impulse starts up in the sinoatrial node and then follows the normal propagation pathway and directionality, the vector should be upright in those leads. This is a normal adult EKG. Again, you can see that the P wave is upright in 1, 2 in AVF and down in AVR. And there is upright T wave progression across the precordial leads. And each P wave is followed by a QRS, and each QRS is followed by a P wave. This is an EKG of a 2-day-old. And what you'll see here is that again, you have upright P waves in 1, 2 in AVF and downright in AVR. In addition, the P wave is also upright in 3, which is normal. But what you'll see is that there are upright T waves in V1. And again, this is due to the relative predominance of the RV mass to LV mass ratio. And upright T waves in leads V1 and V2 are normal in the first 48 to 72 hours of life. However, this is an EKG from a 6-day-old, and what you'll notice is that our T waves have become inverted in V1 and V2, which is normal, and then progressively flipped upright as we go across the left lateral precordial leads. This is a EKG in a 2-year-old, and what you'll see here is again that the T waves have become inverted in the V1 and V2 leads, and however progressively become upright as you go across the left lateral precordial leads. And again, this is sinus rhythm, a P wave followed by a QRS, and a QRS followed by a P wave. And the P wave is upright in leads 2, 3 in AVF and downright in AVR. Sometimes you can slow down the speed of the EKG, and so it's always important to document that. Our standard speed is 25 millimeters per second. This is a 50 millimeters per second. So if you're just looking at it, you would think, wow, this heart rate is pretty slow. I'd call this bradycardia. However, it's important to document the paper speed when determining that. Sorry, I skipped there. If you were to look at this EKG, you would think, okay, everything looks great, but it's important to look over here, and this will tell you the size of our standards across. From the first half of this box is for the body leads, 1, 2, 3, AVR, AVL, and AVF, and the second half stands for the precordial leads, V1 through V6. So what you can see here is that our precordial leads are actually at half standard. So when you're making your measurements as to the height of the vector here, you have to double it. And that's important to keep in mind because you might miss hypertrophy or chamber enlargement. Whereas on this one, everything is at half standard. So again, it's just important to keep that in mind when you're looking at an EKG. If you, upon first glance of this EKG, you immediately come out, the first thing that jumps out is just the height of each of these vectors. But it's important, just as we can have half standard, we can also have double standard. So when you're making these measurements, you actually have to cut it in half, and that will give you the standard measurement. Again, important to know when you're determining if there's chamber enlargement or hypertrophy. Talking about some benign arrhythmias now. Sinus arrhythmia is a variation in the heart rate that is seen with respiration. Whereas during inspiration, our heart rate increases, and with expiration, our heart rate decreases. And this is a normal variant. It's a sign of a healthy heart. Sinus tachycardia and sinus bradycardia are both benign arrhythmias. The reason why they're called arrhythmia in general is because the heart rate is outside of the normal limits. However, this change in the heart rate is not due to intrinsic heart issue itself. It is due to an external factor that is influencing the heart, and the heart is responding. Premature atrial contractions are often considered benign, as are premature ventricular contractions. Sorry, again it skipped. For sinus arrhythmia, as I mentioned, there's phasic variation in the heart rate, whereas heart rate increases with inspiration and decreases with expiration. And as you can see on the EKG strip at the bottom there is an increase in the rate with inspiration and a decrease in the rate with expiration. Again, this is normal. It is seen in healthy hearts and oftentimes in athletes as well. This is actually a pretty common referral in the outpatient clinic setting by general practitioners and pediatricians who, when auscultating, will often hear a change in the rate that can be pretty dramatic, and a lot of times these children will get referred to us in cardiology. Sinus tachycardia is otherwise known as automatic, meaning that the increased heart rate is being generated by the sinoatrial node. It's a narrow QRS complex, meaning it's coming from above the ventricle. The p-axis is normal because, again, the electrical impulse is originating from the sinoatrial node. Usually it's less than 230 beats per minute, even in infants. And oftentimes there's gradual onset and gradual termination. And the treatment is to treat whatever is causing it, a lot of times, such as fever, sepsis, irritability, pain. So these are normal EKG intervals based on age in terms of the standard heart rate. Again, it can be kind of difficult to memorize these numbers, but just know that for most adults it's essentially 50 to 100 or 120 here, and for infants up to 180 can be normal. And in most infants and newborns, less than 100 is considered abnormal. So if you needed to memorize or just have general numbers in your head, those are the numbers that I would recommend. Sinus tachycardia, again, has multiple etiologies, such as fever. If you're in a dehydrated state, the heart is going to increase its rate to maintain cardiac output. Sepsis, in addition, because there is systemic vasodilation in a septic state, so the heart has to maintain cardiac output by increasing the rate. Multiple medications will cause sinus tachycardia as a side effect, and medications are used quite commonly: albuterol, dopamine, epinephrine. Pain, again, can cause, as will irritability, and congestive heart failure. You'll see people who have kind of a resting sinus tachycardia. Again, that is to maintain cardiac output. Cardiac output is determined by your heart rate times your stroke volume. So if you're dehydrated, you're going to have a lower stroke volume. If you're in congestive heart failure, your ability to generate a stroke volume is less because the actual intrinsic pumping action of the heart is depressed. So the body will tell the heart to increase its rate to maintain cardiac output, to maintain distal organ perfusion. Sinus bradycardia, again, it's a narrow QRS complex, meaning it's originating from the atrium. Sometimes we will actually have a different P wave. If the intrinsic sinoatrial nodal rate is slower than an escape rate, meaning a separate area of the heart that will be able to generate its own electrical impulse, then that separate area will then take over. If you refer back to one of my earlier slides, and if you look at that, demonstrated a cartoon of the heart with different action potential morphologies, each of those areas of the heart can generate their own impulse. But those impulses are often generated at a much slower rate than our sinoatrial node. That is why our sinoatrial node is the predominant pacemaker, because it's faster. But if that sinoatrial node becomes slower than one of the other escape pacemakers, then those pacemakers will take over, and your QRS and or your P wave will have a different morphology and a different access. There are multiple etiologies of sinus bradycardia, just like there are multiple etiologies of sinus tachycardia. During sleep time, all of our heart rates should decrease. If we're under sedation medications, it will decrease. Increased vagal response, which increases our parasympathetic innervation of the heart, will slow down our heart, such as seen with reflux or during a bowel movement, especially in infants. Hypothyroidism, hypothermia. If you're in extreme cardiovascular condition, your resting heart rate is going to be quite slow. It's not uncommon for athletes and marathoners to have a heart rate that is in the 30s and low 40s when they're sleeping. In addition, bradycardia is also a sign of increased intracranial pressure, which is actually one of the warning signs. So it's something, if you're ever taking care of a child and that's a concern, very important to keep an eye on the heart rate. PACs, or premature atrial contractions, typically benign, very common. It's estimated that almost all of us will have a PAC every now and then. It's spontaneous atrial activation. And again, you will see a P wave before the QRS morphology. It can be conducted or non-conducted, depends on if the atrial contraction occurs when the AV node is either refractory or not refractory. If the AV node is still in its refractory state, it will not be conducted to the ventricles. If it is in its, if it has already gone through its refractory state, then the atrial contraction will be conducted down to the ventricles, and you will see a narrow QRS or a normal QRS complex for that patient. In addition, it can also mimic second-degree AV block if it's not conducted. However, the ability to tell the difference on an EKG is if you get a rhythm strip, and if you march out the P waves and you look at the interval between each P wave, the PAC will occur earlier than what you normally would anticipate. Whereas in second-degree block, that atrial interval or P wave interval remains constant. In terms of the compensatory pause, it's incomplete because the PAC will reset the sinus node. So if you have 2 cycles, including your PAC, it will be less than 2 normal cycles. So if you look at the EKG rhythm strip here, going from left to right, you can see that the first 2 cardiac cycles there have a atrial cycle length of about 0.86. Whereas if you look at the PAC cycle, that actually is decreased to 0.5. So if you include the cycle, including the PAC, is less than 2 normals, and that's a telltale sign that there's a PAC. In addition, after the PAC, you see that there's a little bit of a pause, as evidenced by a lengthening of the next P to P interval. And again, that is because you're resetting the sinus node. In terms of working up, if it's deemed that they're causing an issue, you can always check electrolytes, particularly your potassium, magnesium, and calcium. You want to make sure that they do not trigger any runs of atrial tachycardia. And in people that are known to have reentrant supraventricular tachycardia, it can trigger it. And we will discuss that later during that lecture. The treatment essentially is to treat the underlying etiology if one is found. Avoid stimulants such as caffeine; those have been known to cause PACs. And also, if you have intracardiac lines where there's a distal tip in the atrium and it's kind of, I guess the best word is tickling the inside of the atrium, that can cause a PAC as well. Premature ventricular contractions are quite common, seen in almost up to 20% of infants less than a month of age. However, by a month of age, usually it decreases substantially to less than 10%. And again, this is spontaneous automaticity from the ventricles themselves. It's oftentimes a wide QRS complex, secondary because the electrical activation of the ventricular myocardium occurs myocyte to myocyte, rather than conducting down the normal Purkinje system. So it is a slower depolarization, hence the wider QRS complex. They can be monomorphic, meaning the morphology of each PAC is normal, indicating that the spontaneous automaticity is coming from one region of the ventricles, versus polymorphic, or multiple different morphologies, indicating that the spontaneous automaticity is coming from multiple different sites within the ventricles. Singles, meaning occurs one at a time and in isolation. Couplets, meaning you get 2 in a row. Triplets, 3 in a row. And in addition, which you'll see sometimes people classify as bigeminy or trigeminy, meaning that you'll have a normal sinus beat, a PVC, sinus beat, PVC, sinus beat, PVC, and that's indicative of bigeminy, whereas in trigeminy you have a PVC every third sinus beat. So it is spontaneous automaticity from the ventricles, as I mentioned. You do not see a P wave before a PVC. Therefore, it does not reset the sinus node. And 2 cycles, including the PVC, equals 2 normal cycles. What I mean by 2 cycles equals 2 normal cycles is that if you take your calipers and you march out the P to P interval, if you keep on marching through the PVC, you'll see that you will eventually line up with the next P wave after the PVC. And that's indicated here by the red lines across the rhythm strip. So each diamond on the end of the red line indicates the tips of my calipers. So if you march it through, it lines up, meaning there is no pause or there's no compensatory pause of the sinoatrial node. So the workup for PVCs, if indicated, again, is a history and physical to see if they are symptomatic or not. You can do a 12-lead EKG, maybe even a Holter to determine what we call the arrhythmia burden, or the number of PVCs over a given time period. Again, if there are any other etiologies found, such as electrolyte abnormalities, metabolic disturbances, toxicities of various drugs, or if the child or the patient is suffering from cardiac injury, such as that seen myocarditis, or from direct cardiac trauma from an indwelling catheter. Again, these can all be etiologies and must be addressed individually. If you find on history or family history that if there's a history of recurrent syncope or actually sudden death, then these PVCs must be worked up, and we consider them malignant until proven otherwise. If your arrhythmia burden or ectopy burden is increased with activity, that is considered abnormal and must be worked up, whereas if they decrease with activity, then they are considered benign. Polymorphic or multiform morphology is considered malignant versus the monomorphic or single morphology appearance. And again, if someone is symptomatic with PVCs, then they require treatment. And again, the treatment is treat the underlying etiology if found, avoid stimulants, and in rare cases we will bring these people to the EP lab to try to determine the ectopic automatic focus to try to ablate it. That is the end of this lecture, and I will be happy to answer any questions that you may have.